Welcome to my talk entitled Anxiety is Inflammation. It's a pretty bold thing to say, but by the end of this talk I think you will all agree with me about that. I want to start with a few breadcrumbs and sort of work my way back here. In our clinic we've found the same type of connections between maltreatment to girls and higher levels of inflammation later in life. We see obviously the adults who have gone through these traumas and presenting with physical and mental illnesses, which most psychiatrists would say are comorbidities. But more specifically, the summary of this was that girls who were abused in early life have higher levels of inflammation than boys who are maltreated and other children who do not experience abuse. They correctly go on to say that inflammation plays a role in many chronic diseases of aging, diabetes, cardiovascular disease, stroke, obesity, as well as mental health outcomes. And the findings suggest that maltreatment's association with inflammation does not lie dormant before emerging in adulthood. Instead, the study shows that the traumatic experiences have a more immediate impact. What they're saying is that if you were to follow interleukins, say 6, interleukin 8, the trauma initiates the interleukin release from the moment that the trauma has happened. We'll come back to why this is, but to jump to the middle of the story, those girls with low GABA who are traumatized are more likely to go on to this. Another thing you might see out there in all sorts of places, but if you look at the Mayo Clinic's forums on anxiety, I found this. Vitamin D has helped me with my anxiety attacks. So how could that be? They weren't actually taking very much vitamin D, by the way, 3,800 IU. I'm going to say something that is probably pretty obvious if somebody points it out to you, and that is that inflammation is not just a symptom that is physical. There's an emotional component to inflammation. So when somebody injures themselves, they have an emotional reaction to it. If someone has arthritis, there's an emotional reaction to that arthritis. Or if it was a bladder infection, there's an emotional component to inflammation. Now, we tend to split these things up. We tend to say, oh, you have a physical pain or an inflammation and you have a mental symptom, and we don't actually take the possibility that they're the same thing. Alright, so not all inflammation is painful. For instance, if you were to split them into groups of obvious and not obvious, most people would agree meningitis is an itis, encephalitis is an itis, migraine is an itis. All of these itises are felt as pain, but there's some not so obvious inflammatory patterns, and that is things like brain fog, depression, anxiety, bipolar, etc. My point is that the central cause of these symptoms can create obvious and not obvious itises, and the term inflammation in some ways is misleading because it implies pain. Now, did you see there for a nanosecond that schizophrenia is an itis? Absolutely. The autoimmune model of schizophrenia. And this was published 10 years ago and verified, and I doubt if there are many psychiatrists who understand that their schizophrenic patients have inflammation. They would say it the other way around, that the patient has schizophrenia and some comorbidities. We use the Braverman questionnaire a lot more now as a tool to understand and link what we're seeing biochemically and functionally with the symptoms that present. So many patients about 80 to 90% of our patients who turn up with other itises have this as their score on their Braverman questionnaire. Why is that? And we'll see that the symptoms of anxiety which would come from GABA deficiency are also the symptoms that they're presented with in a physical sense. I'll give an example. How happy are you when you itch? How happy are you when you sneeze? So the itis in both of these, the dermatitis and the rhinitis, have an associated emotional response, which we think is the reaction to the itis, but in fact they are the same group of, they are a cluster of symptoms. So coming back to this, would vitamin D really help anxiety? So if anxiety is an itis or an inflammation and vitamin D helps inflammation, is it a given that if you improve the vitamin D levels you will improve the itis and therefore the inflammation? In large-scale studies they've looked at this, and it seems that vitamin D can help in many psychiatric disorders, but not necessarily in anxiety. So anecdotally you might find a whole heap of patients respond to vitamin D for their anxiety, but when you look at a large group of them, there doesn't seem to be a very strong correlation or a statistically significant correlation. Now why is that? If you were to measure inflammation markers, and our current level of inflammation marker testing is quite limited, but let's say that you could, and you were to increase the vitamin D level in that person, 60% of the population will show a reduction in inflammation markers as you increase their vitamin D. But 40% of the population will seem to be resistant. And if you don't go far enough with the vitamin D, and I don't mean into the toxic range, just at the top of the range, you'll find that there's a plateau period where increasing the vitamin D doesn't seem to make a lot of difference until you get to some tipping point, and then you see a reduction in inflammation. So it depends on which group was tested. If you had a population that was predominantly sensitive to vitamin D, you might see an improvement in anxiety, but generally they don't screen patients in these studies in that way. One of the reasons for this is the receptors for vitamin D on the surface of the cells have a spectrum of sensitivity. For some people they're like a rabbit. They've got really good hearing. You don't need a lot of vitamin D in the bloodstream to trigger a response in the cell. So if that person took vitamin D and they had anxiety, it's likely that the anxiety would improve. And in the case of the person who took 3800 IU, I would say that they probably had very good vitamin D receptors. But as we move to the average and then to very bad, giving that amount of vitamin D would probably not necessarily change the blood level that much, and it certainly wouldn't initiate an anti-inflammatory response. To understand this, we need to have an insight into the genetics of vitamin D metabolism. So for instance, in the Wellbeing Bundle reports, there are 6 genes that affect vitamin D production. So you might be good at making it from the sun, you might be good at making it from cholesterol, you might be good at activating it in the liver, you might be good at activating it in the kidney, you might have really sensitive vitamin D receptors, and you might break it down really slowly, or you may have the opposite, which is what this example is. So the full circles pay close attention, and this person has all of the groups that have an issue, especially the vitamin D receptor. So if you have a vitamin D receptor in the full circle like this, it means that you are in the category of very deaf vitamin D receptors. Now if we look at the on-flow effect of a low vitamin D, and this applies to whether it's low or whether it's ineffective, either of the two scenarios winds up with the same problem, and that is If you're going to the right of the screen, you'll see we have a low serotonin. That's because vitamin D is needed to activate one of the enzymes that make serotonin. And then if you have low serotonin, you're going to wind up with things like depression, anxiety, sleep issues, inflammation. See, anxiety is in that list. Vitamin D is important for absorption of minerals like zinc, calcium, magnesium, manganese, iron and copper. So the drop in magnesium, for instance, could lead to anxiety. Vitamin D is important as a defense system against infections, encapsulated viruses, yeast, bacteria. Vitamin D is an anti-inflammatory, so when it's low, you're likely to see higher levels of inflammation. And typically the interleukins that we see with this problem are interleukin 6, interleukin 8 and TNF alpha. One of the problems therefore when this happens is ongoing inflammation, unabated inflammation, will eventually require the adrenal glands' help to make cortisol. And that mechanism of supporting inflammation is meant to be for a short-term purpose, a few hours. It's not meant to be weeks, days, months. And eventually that system will have a certain capacity, and then it's going to have to need support. And the first port of call for support is to drain progesterone levels in order to satisfy the cortisol levels, because we need to make cortisol from progesterone. The problem with that is as soon as you lower the progesterone, you inadvertently change the balance between progesterone and estrogen. And that condition is called estrogen dominance, and it has its own plethora of symptoms. Now, coming back to this idea that GABA might have an impact on inflammation. If we have a look at the GABA receptor, so we have the outside of the cell here, we have the inside of the cell here, and what's unusual about this transmembrane channel is it allows chloride through, which increases the negative potential on this side of the cell, which is already a negative. It means it's harder to stimulate that cell. It puts it into a relatively numb characteristic. And there are 5 parts to this receptor. One part can be stimulated by GABA, another one by GABA. The next one are the benzodiazepines or the PAMs, diazepam, clonazepam, oxazepam, flunitrazepam. They all have a binding to this. We've got alcohol that will bind to this, same as where the volatile anesthetics bind to. Halothane, influene, isoflurane, these sorts of volatile anesthetics which you use in general anesthesia. Then we have propofol, which binds to this side, which also is a general anesthetic but an intravenous anesthetic. This was the drug that Michael Jackson was getting at night to help him sleep, because his PAM, he had exceeded his ability to utilize PAMs and probably had exceeded his ability to put himself to sleep with ethanol, so his doctor was giving him propofol at night. But another site, this same propofol site, is where the neurosteroids can act, which has a calming effect. And the neurosteroid, as we identified, as a thing called allopregnanolone. And this, surprise, surprise, is made from progesterone, only if you take it orally. And the reason is that this happens in the liver. So if you take transdermal progesterone and that transdermal progesterone goes straight to the brain, it's not going to have this effect. It has to be converted by what we call the first pass effect. But you can see here that the production of this depends on cortisol. So if cortisol is busy putting inflammation out somewhere else, there's going to be less of that, and then there's going to be less of that, and then there's going to be less of that. So you can see that chronic inflammation is going to have an adverse effect on the calming effect in the nervous system. It's going to have the opposite of calming. What this means is, and we'll come back to this, if we take the stimulatory neurotransmitters, acetylcholine, serotonin, histamine, and catecholamines. When these four elements get out of hand, the normally balanced tetrahedron is thrown into chaos, and the brain doesn't like it. So if the normal regulatory mechanisms that deal with this can't be invoked, for instance, if you can't break down catecholamines because you've got a slow COMT gene, or you can't break down histamine because you have a slow MAO or a slow DAO, or you can't break down serotonin because you have a slow MAO, then somebody has to come to the rescue, and that rescuer is GABA. So you can see in this, GABA is a bit like cortisol of the brain. It's a mechanism running in parallel to the calming neurotransmitters, or calming neurosteroids, that helps to produce a calming effect. And just the same way as we call the adrenal gland with this out of control inflammation to make cortisol, we call the brain to make GABA. Now, what might not be so obvious is all of these steroids are made from cholesterol, and the pathway to make that is you convert cholesterol to progesterone, then you can send it off to cortisol, or you can send it off to estrogens, and you can send it off to androgens. And this balance, this tetrahedron, basically controls the immune system. Anything that puts this out is going to have a problem, and it might be infections, allergies, cancers, and autoimmune disorders. And if you look at the plethora of information about hormones and that, you can see that the higher rate of autoimmune disorders in females. Progesterone has been used as an antihistamine. Cortisol obviously can be used for improving inflammation or if you have an allergy. But I'll give you an example, very good example. Cortisol, when it's low, creates a condition called Addison's disease. And people with Addison's disease get more infections. The opposite of that is that people with high cortisols have a disease called Cushing's disease, and people with Cushing's disease also get more infections. And this we've known for quite a long time, but until you've seen this diagram, you probably wouldn't understand the delicate balance between these four groups. So coming back to the inflammation side of things, if vitamin D is ineffective, there's going to be more strain on this part of the anti-inflammatory pathways, and it's going to cross over into hormones. Now you already see why females are more likely to have an issue. Now, the messages that the immune system gets to make these interleukins is coming from the brain. And that's probably a big surprise. But the war room for fighting against threat is in your head. It's not in the spleen, it's not in the bone marrow, it's nowhere else but in the brain. So the brain is sending messages to the rest of the immune system about how to deal with threat. So you can think of the interleukins as chemical messages. We have different pawns and different pieces on the chessboard, and some of them might be to make antibodies, another one increase the CRP, the other one is stop inflammation, up the TNF alpha. They're all messages coming from the brain, rather like neurotransmitters. So these messages equate to attack, desist, heal. What moods would correspond to messages like that? Well, attack, let's say it's a pro-inflammatory interleukin, it would be to fight, or be frightened, or anger or anxiety. Desist, which is the anti-inflammatory interleukins, relax, stop fighting. And then heal, it's going to be okay, is when there's an abatement of the inflammation where the site has been cleared. This is really important because You cannot heal something until the inflammation is gone. It's like having a fire in your kitchen and you call a handyman in to replace the cupboards. He's going to turn up there and look and go, hey, it's still on fire. Call me when it's finished and I'll come and repair it. And the body's exactly like that. What that means then is that the neurotransmitters are somehow involved in immunomodulation. They also are involved in the messaging about what should be attacked, what should be not attacked, what should be healed. And the 5 groups here: histamine, serotonin, taurine, and glycine. And that's only 5 of the 22 amino acids that we've studied have some immunomodulatory effect. For instance, taurine and inflammatory disease. Most of the fundamental effect of taurine is related to an antioxidant property. For instance, we don't make any proteins with taurine. So why do we have that? It's there as a modulator. It calms the immune system down. That's why we use taurine in anxiety, epilepsy, these types of things. But it's predominantly present to be an antioxidant or an anti-inflammatory. They are synonymous. Glycine, a novel anti-inflammatory, immunomodulatory and cytoprotective agent. So here's an amino acid that is used to construct proteins, but it also has another job, and that is it's a neuroinhibitory neurotransmitter in the brain, but outside that it has this anti-inflammatory function. Serotonin, and these aren't just single studies, these are correlations of dozens or hundreds of studies to find a pattern. So the role of serotonin and its receptors in the activation of immune responses and inflammation. The role of GABA in the mediation and perception of pain. So GABA isn't just a calming neurotransmitter, it actually alters how you perceive pain. So if we look at the symptoms of GABA deficiency, and you can define a neurotransmitter in 2 ways. You can either define what it does, or you can list the symptoms that someone will get if it's missing. And this is a list of the GABA deficiency symptoms: irrational fears, apprehension, initial insomnia, poor concentration, social withdrawal, feeling vulnerable, irritability, and in severe cases, movement disorders. That includes periodic movement disorders, epilepsy, seizures, and sometimes tics. Now, coming back to the trauma-GABA relationship. The relationship between post-traumatic GABA plasma levels and PTSD at 1 year follow-up. What they found was all of these patients had low levels of GABA, which implies they had low levels of GABA at the time of trauma. Now, GABA is released in massive amounts to protect the mind from trauma. It's an amnesiac. If you think about the PAMs, for instance, and how they can be used for twilight anesthesia, when we give a person a dose of diazepam prior to a dental extraction, the idea is that they don't remember it. So GABA has this effect. And we can see that other things have similar amnesic effects. For instance, the PAMs, propofol, the volatile anesthetics, and this is why they're used in general anesthesia, not just to induce anesthesia but also to induce amnesia. And ethanol, the number of people who say, oh, I overdid it last night and I cannot remember what I said. Did I say anything bad? How many times have you heard that story? Because it induces GABA, which is the same amnesic effect. So the same brain that is sending off the cytokines to war is also the same brain that releases GABA in the process of trauma. And so if the brain is numb or numbed, you won't get the same cytokine release. if there's lots of GABA in the brain. You will obtund the pro-inflammatory reaction to that trauma. So if we have a look at this graphically, let's say we could measure GABA and interleukins after trauma. We'd find that in a normal person, interleukins are at a baseline level, GABA is at a baseline level. We have the trauma, and then we have the GABA release, which is transient, and then we have a release, modest release of interleukins, which goes back to baseline. That's in a person with normal levels of GABA. If you had a low GABA, then obviously your levels of GABA will be low, your interleukins might be the same. You're traumatized, there's a pitiful release of GABA and not enough to obtund the higher interleukin release. So we'll go back. So a number of times we see this pattern of GABA deficiency. There's a high likelihood that the patient who is presented has had some type of trauma involved in producing their inflammation. Now, if we look at the neurotransmitters separately, we don't quite get the same understanding of the palette of emotions that a person can feel. Let's say we had a mixing desk where we could mix our neurotransmitters. We've got serotonin, melatonin, dopamine, histamine, noradrenaline, acetylcholine, GABA, theanine, and the endorphins. And everybody has a different mixture of these, and these mixes are designed to create a palette of emotions for us. Combinations, an infinite number of combinations, can produce different emotions. Now wait a minute, if these same neurotransmitters are immunomodulators, then where the mixer sits will affect the inflammation in the body as well. For instance, a low GABA will not only throw this whole mixer out of balance, but it'll set somebody up for a problem. If a person like this is traumatized, then they're more likely to go on to inflammation. And it's because GABA is not only a mediator of pain, but it seems to be the particular neurotransmitter involved in autoimmune inflammation suppression. And that's a revelation that's really, really important. Have a look at the date of this article. 2009, we've known that GABA has an influence on the protection against autoimmune inflammation. So does that mean that post-traumatic stress disorder is an immunological disorder? Damn right it is. If you stress someone or traumatize someone with a low GABA, and the GABA is designed to prevent autoimmune inflammation, then PTSD is likely to be an immunological disorder. Which means that, again, psychiatrists will say, oh, you have PTSD and your comorbidities are asthma, osteoarthritis, etc. But in fact, they're the same disease. So now we have to update the symptoms of GABA deficiency and add at the bottom, under the movement disorders, autoimmune inflammation. Just as an aside, a medication that we use for chronic pain to reduce pain is actually being used for generalized anxiety disorder. And this medication is pregabalin, which would make sense after what I've shown you in the above slides. But why would GABA be low? I mean, that's the big question. What are the influences on GABA levels in the body? Well, any neurotransmitter is basically made from three ways. You can either get it whole in your diet if you good at absorption and you've got a good diet. Your gut bacteria might make it for you, or you might have to make it yourself. So the dietary sources of GABA. And please make sure that the Therapeutic Goods Administration never see this list, because what you'll find a few months later is you won't be able to buy almonds, bananas, beef liver, broccoli, brown rice, halibut, lentils, oats, oranges, rice bran, spinach, walnuts and whole wheat products. Or we can make GABA. So we start with glutamine. Our greatest sources of glutamine is actually gluten, which is about 60% glutamine. We have a few enzymes, we convert it onto glutamate, and then we convert it to GABA, or our gut bacteria can provide the glutamine, or the gut bacteria can provide the GABA directly. The gut bacteria that make GABA, at least these four: Lactobacillus hilgardii, Lactococcus lactis, Lactobacillus rhamnosus, and Lactobacillus paracasei. Now, you might think it's just some linear journey to go from glutamine to GABA, but there's an intermediate that sometimes people get stuck at. Now, we get stuck there deliberately when we're learning something, because when the glutamate is high, it activates the NMDA receptors, which are integral in how we learn things. But then we want to calm down, so we either go to the right of the triangle here to glutamine, which is a calming neurotransmitter, or we go on to GABA, which is a calming neurotransmitter. But we don't really want to get stuck here. We want to visit there and go back. A breakthrough in neuroscience showed that wakefulness is governed by GABA and histamine being released at the same time. So the stimulatory neurotransmitter histamine is balanced by the inhibitory neurotransmitter GABA, in order to produce wakefulness but not overstimulation. This is very similar to the immune system's function, that when we send pro-inflammatory interleukins like interleukin 6, we also send a message to the lymphocytes to release interleukin 10 as the natural fire extinguisher, to make sure that the collateral damage isn't severe. So in a perfect world, the mixer might change this way to create wakefulness. When histamine is released, so is GABA. The relative proportions of them stay the same. We are wakeful but not overstimulated. The problem is that for women, they have more histamine in their central nervous system than men. And this imbalance between histamine and GABA will be amplified because of this. So the genetics of mast cell release show that estrogens stimulate mast cell release, which will then create a histamine load, which in the periphery should be mitigated by GABA. So we have this situation. There may be a reasonably higher level of GABA, but the histamine will always outplay it. Now, histamine is pro-inflammatory. Apart from a whole heap of other things, histamine reduces interleukin 8 secretion by endothelial cells. And the problem with interleukin 8 is that it has a very long profile time. It's about 6 to 8 weeks. So interleukin 8, one way to think of it, is a pro-inflammatory cytokine, a bit like artillery. Here's the weapon here. But histamine is the actual shells for this weapon. So that's fine if you make extra interleukin 8 and don't have any ammunition. But if you do have a histamine load, you're going to have more damage done from interleukin 8. And if you're female, you're going to have higher levels of histamine. So what if you had this situation? The GABA response cannot keep up with the histamine release. And we know that histamine has a pro-inflammatory effect. The GABA has an anti-inflammatory effect. The GABA is released in the brain when extreme situations occur, when there's an out of control tetrahedron or the histamine is very high. GABA is the cortisol that puts the whole fire out. That might explain this a bit more. Why these high inflammatory profiles occur in girls who are maltreated, because their histamine GABA ratio is likely to be in favor of histamine, and they're going to go on to a cortisol drain, which will then influence their hormones later on. So 60% of the population might improve with vitamin D because of its anti-inflammatory effect. But if you had this problem, which is the vitamin D in the deaf zone, you're going to have issues with the efficacy of vitamin D even if you take it. So here's my point. If all inflammations have an emotional component, then anxiety could be one of the symptoms, and that's why anxiety is inflammation. Well, thank you for watching, and I hope you've enjoyed this video.